Antimicrobial resistance, a social dilemma problem. So, Eva?
Thank you very much. Thank you. First of all, can everybody hear me okay? I do have a bit of a quiet voice, so if ever I go quiet or silent during the talk, just maybe give me a heads up and I'll speak up a bit. Thank you very much for the kind introduction, and thank you so much to Kevin Denny for inviting me to give a talk here. It's a real pleasure to be here. And I actually know Kevin from social media, from Twitter. So we started following each other's tweets, and realised that we had quite a lot of interest areas in common. And it was very nice for me to see how social media can actually lead to some real contacts and can kind of grow into larger collaborations. So yeah, that was a really great experience actually. So I do have my Twitter profile on there. Do feel free to tweet or get in touch afterwards. I always welcome any feedback you might have. So, as you've already heard, my topic today is antimicrobial resistance, a social dilemma problem. And I jump right in by just giving you a brief overview of my talk. So I start with an introduction, then dive into the problem of AMR. That is what I'm going to call antimicrobial resistance for the rest of the talk. I will then talk a bit about the project team that I've been involved with for about 2 years now. Then I will present some of the theory we've been exploring, and outline a project, a multinational qualitative project on antibiotic prescribing, as well as some preliminary results. Then finally, I'm hoping I will draw some interesting conclusions, and perhaps we can have a bit of a discussion about it afterwards. All right, first of all, where am I from? I'm from the University of Leicester, so that's kind of like in the middle of the UK. Sort of like an hour away from London, really. It's probably most famous recently for its football team, the Leicester City Foxes. Personally, I'm really not into football, but I have heard that apparently they won some major title a couple of years back, so well done. We're also quite famous for Richard III, whose human remains have been found buried underneath a car park in Leicester. So if you're interested in history, I do recommend checking out his reburial site in Leicester. Quite interesting. And then finally, Leicester's probably most remarkable monument is the clock tower down there in the corner. It's really not that exciting at all. There are many good things to talk about in Leicester. Lovely curry houses, great multicultural city, but it's definitely not its sites that it's famous for. And I do actually think that this picture is slightly misleading, because most of the time Leicester really looks like this. So, especially now, coming to autumn, run up to Christmas, it's usually quite grey and cloudy and pretty wet as well. So at Leicester, I'm based at the University of Leicester, so there's two different universities. The main one, based in the College of Life Sciences, and I'm an employee of the Department of Health Sciences. And within that, I'm a member of the research group called Sapphire. That's social science applied to healthcare improvement research. And I actually always have to look it up because I can't actually remember the whole title, it's just so long. But basically, we're like a mixed bunch of social scientists, some sociologists, psychologists, geographers, looking at healthcare research and how to improve healthcare in the UK and internationally. Now, as Doran already mentioned, I started off my academic career actually looking at more experimental research on reasoning and abstract decision-making scenarios, or abstract games. So what you might see up there, quite abstract mathematical games. And I very much enjoyed this kind of theoretical focus and thinking about social dilemmas, but I very much felt that it'd be more useful for me to move into a slightly more applied area. So I've made that move, that transition to study real social dilemmas rather than those abstract ones, and looking specifically at the healthcare sector. And that's really what my talk is going to focus on today as well. So I gather not everybody here are clinicians or have a medical background. Actually, can I have a show of hands who's got some sort of medical background here in the room? Okay, well, one person, that's fantastic. So I might start off a bit slower then. I'm obviously not a medical background myself. I'm a psychologist, and I've tried to read on that necessary knowledge, basically. But I hope I get everything right. If not, you can always correct me. So basically, I'll be talking about antibiotics, which are a type of drug or class of drug that acts against bacteria. and bacterial infections. So bacterial infections can be pneumonia, for example, or urinary tract infection, but quite crucially, they're different from viruses, which are usually the causes of most kind of flu-like symptoms. So antibiotics are used typically to treat infections, and they're being prescribed to obviously kill off the bacteria and the pathogens. However, there is always an issue there, a natural risk involved by administering antibiotics, that bacteria might develop what is called antimicrobial resistance, or AMR. And basically, that resistance means that the bacteria become resistant to the treatment, so they no longer respond to the antibiotics that we've got available. Now, just to talk you roughly through the process of how that actually happens, like I said, it is a natural process. So we start off with an environment where there's lots of germs, lots of bacteria. Some of them happen to be naturally resistant to antibiotics. So it's just depending on their genes, basically. Now, if we go into that environment and administer an antibiotic, that would kill off all the bacteria that are not resistant to treatment, leaving only those red ones there, so the ones that are resistant. Now, with the other ones being dead, the red ones are then able to kind of multiply and increase over time. So basically, they're going to take over, which means that the overall number or proportion of resistant bacteria will increase. And they might even then pass on some of their genes, their resistant genes, to other bacteria. So on the whole, just increasing antimicrobial resistance and the problem. And this is really a massive issue, and it's predicted to, this is looking quite grave, I have to say, it's actually predicting to cause a lot of deaths, to overtake cancer as a major cause of death by 2050. And the reason for this is, antibiotics are used in all areas of medicine, basically. So they accompany cancer treatments. They're used for surgeries to prevent infections, surgical site infections, and so on. So it is really a big issue, and people usually underestimate how much we really rely on antibiotics in our current healthcare system. Now, there's a lot of different factors that might contribute to antimicrobial resistance, one of them being overprescribing of antibiotics, and that really is the area that I'm going to focus on my talk. But just so that you are aware, there are other areas as well. So, for example, patients not taking the antibiotics as prescribed, so either taking too long or too short a course of treatment, then unnecessary antibiotics, which are being used in agriculture, poor infection control in hospitals and clinics, and equally poor hygiene and sanitation practices, because those poor infection control measures will then lead to bacterial infections to spread, which means more people will get sick and more people will need treatment, which again means you have to administer more antibiotics and you increase antimicrobial resistance. And then another issue that is still causing problem is the lack of rapid laboratory tests. So usually what happens when someone presents with symptoms of a bacterial infection is that doctors in a hospital will take some samples and send them off to the microbiology lab in order to test what is actually underlying those symptoms. At the moment, however, it takes about 3 days most of the time to get those lab results back. So there is quite a bit of time involved in getting a clear diagnosis of the underlying issue. Now, with that in mind, doctors can't always wait for that long to make their prescription. So there's quite a lot of area of uncertainty and like a grey zone where they have to rely on their personal experience and empirical prescribing approaches. So that can then lead to overprescribing because you don't have that very clear diagnosis of what's happening. So as I said, the project that I'm presenting, the work that we've done, focuses on overprescribing of antibiotics and actually specifically on overprescribing in hospital settings, although some of it will definitely also be appropriate or applicable to the general practice sector. Now, I've already mentioned the project I'm involved in. The acronym is a MAIA project, Antimicrobial Resistance Project. And the aim really of this was to study AMR using a theory-guided but also empirical approach, and looking at AMR in 3 different countries across the world. So it was an international, interdisciplinary, and multi-method research approach. The 3 project countries were the UK, Sri Lanka, and South Africa. And we had a very mixed research team with varying expertise, including social scientists and clinicians. And then we used a combination of theory, qualitative methods, and modelling techniques. And I will go over those in just a moment. So So just to kind of put this on the map, you see the main project team is based in the UK here. That's Carolyn Tarrant, she's the principal investigator, and I was the main researcher on the project. And then we also had colleagues in Sri Lanka and in South Africa who then helped us gain access to the hospitals there where we collected our data.
Sorry, could you just say a little bit about the choice of countries involved?
Yes. So I have to admit, firstly, we wanted to have a kind of a broad range of countries from different continents, and we wanted to include some countries from a low and middle income background, so that's why we chose Sri Lanka and South Africa, which have got that lower income. Now, for practicality reasons, we did want countries that spoke English so that we could conduct all the interviews in the English language. And again, for practicality reasons, we chose countries where we already had existing research contacts. But actually, in hindsight, we're really happy with the countries we chose because we realised that they had a very interesting mix of different regulations going on in their countries, and also interesting differences between the private and public sector in those, especially the other countries, Sri Lanka and South Africa. And I'll be talking about those further on. Yeah, just to kind of give you a different split here, so you can see the top 4 people are social scientists, and we also had 3 microbiologists on the team, 3 consultant microbiologists, Melon Pereira from Sri Lanka, David Jenkins based at Leicester, and Shaheen Mehta from South Africa. Very quick overview again of the collaborators, but if you want any more information on those, you can always email me afterwards or ask me for further information. Now, the project that we got involved in was funded through a pump priming grant, so a fairly short grant that was supposed to just explore the topic and then hopefully generate some future follow-up ideas for a larger study afterwards. So it was for a timeline of 2 years, and we started off in January 2017 with theory development and some exploratory research visits to Sri Lanka and South Africa. This was followed then by qualitative data collection in all 3 countries, as well as analysis. And now we're really in the final stage where we're drawing conclusions, kind of doing some more analysis and doing some agent-based modelling to use the results that we gathered in order to predict the possible effectiveness of intervention studies in the future. But let's start with a bit of theory. So like I said, that's what we started out with. It was a theory-based empirical study. And as the title already gave away, I want to talk about social dilemma theory here. Now, social dilemma theory kind of stems from the area of economics and game theory, actually, which is very much where my PhD was grounded or based in. And it's basically talking about or kind of formalizing the conflict between the individual and society at a larger. So what do I mean by this? If you think about antibiotic prescribing, you have on the one hand the individual patient that's in front of you. So the patient who presents to hospital with symptoms of an infection, who's acutely unwell. On the other hand, you have society who is generally interested in very in restricted prescribing approaches of antibiotics. So if I spell this out a bit more clearly, basically when the patient comes in, he's at risk of at an immediate direct risk of mortality. So if they have a severe infection, they might die very quickly. So obviously, as the patient, they have an interest in unlimited prescriptions of antibiotics. If they have an infection, that would mean they get treated really quickly and that they will probably make a speedy recovery. If they don't have an infection and the antibiotic is given unnecessarily, well, that might lead to some side effects and possibly a disruption of the flora in the stomach. But it doesn't really have that big a side effect that it would present a large risk. So for the patient who is suspected to have an infection, it's always better to prescribe the antibiotics. On the other hand, you have society as a whole, who is at risk of developing antimicrobial resistance in the future. So they're very much interested in a conservative and very targeted treatment approach. Now, what do I mean by that? Basically, only prescribe antibiotics when they're strictly necessary. If possible, target the treatment. So use the lab results that you might have gathered or received to use antibiotic treatment that's very targeted and narrow spectrum, so specifically targeted towards a specific pathogen that's underlying the infection. And the narrower spectrum antibiotics are in contrast to more broader spectrum varieties that might target a wider range of pathogen, but then also increase antimicrobial resistance quite a bit more. Now, within social dilemma theory, there's a particular type of social dilemma, the tragedy of the commons, that might be most applicable to the dilemma of antibiotic prescribing. So the tragedy of the commons was first presented by Hardin in 1968. It's like a core social dilemma, basically, that's been discussed a lot in the literature. And the original example was given by Hardin actually talked about a piece of farmland, which they call the common. So it's basically a common piece, a public good that's available to all the people living in an area of that farmland. So just imagine having like a neighbourhood of different farmers around, and they might all send their sheep there to graze. Obviously, every farmer is benefiting from this because their sheep are getting fed. And then they might think, oh, hang on, maybe I just send a few more sheep over to the grassland just to gain more benefit from it. However, the more users do that, the more farmers send their sheep to the common ground, the more it actually becomes degraded. So the grass might turn brown, it might disappear, and eventually you might have such an overuse of the commons, of the farmland, that it becomes unusable. So really, what this scenario shows is that the overconsumption of resources for the short-term gain leads to an outcome that's worse for all. So initially it might look like for the individual it's better to send more sheep on it, but if everybody acts selfishly, then everybody is worse off in the long run. And that's exactly the kind of model that we believe applies to antimicrobial resistance as well. So just to kind of make that connection here, we might start off again, if you remember the diagram from the beginning, we have got lots of germs here, very few will be resistant naturally, and then if we administer an antibiotic, it will be effective initially. So I've got the antibiotic here, powerful and strong, very big, to showcase the antibiotic efficacy. And that's really what is the common good in this example. So in the previous scenario, we had the grassland, the farmland as the common good. Here it is actually the antibiotic efficacy. Because the more you administer antibiotics here, the more you actually increase resistance, and then the common good, the antibiotic efficacy, becomes depleted until eventually it's so tiny you can hardly see it anymore. So basically meaning that, well, the antibiotics that we've got at the moment, they won't do any good anymore in treating infections. And this is actually a really severe problem, something that I should have mentioned earlier actually. There are very few antibiotics newly developed, so it is almost like a finite resource, which is why it's so important to preserve the antibiotics that we've currently got. Now, just to summarise the dynamics of this social dilemma, the rational self-interests are very prevalent here, so individual patients will always get a better outcome from overprescribing, regardless of what other people do. Importantly, each individual patient makes a very negligible contribution to the problem, so any one instance of prescribing won't really make a big difference. The individual contribution of each patient is very probabilistic and intangible, and that means that the responsibility is spread across multiple communities of antibiotic users. So you can't say any one patient is responsible because they've used antibiotics. It's just such a large problem because so many users are there that the responsibility is very hard to pinpoint, and that also means it's hard to blame any one person. Now, just to give you an overview of some of the work that's been done in the area, so there have been a few papers actually looking at AMR and social dilemma theory, some good papers from economists actually, but none of them have really delved into the topic to greater detail, and actually we have and discussed it in more detail, and we've come to think about whether AMR and social dilemma theory are actually a very perfect theoretic fit. So I'd just like to discuss some of the complications perhaps that AMR presents, which might mean that it cannot actually be completely conceptualized or modeled as a social dilemma. So first of all, we have a lack of visibility and imminence here that's really important for antibiotic prescribing, makes it just that much more complicated to deal with. So importantly, AMR mostly affects future generations. It is a very loosely coupled abstract future threat, and many current patients and doctors actually will never experience depletion of antibiotic efficacy. It is a problem of the future because at the moment, even though we do experience cases of antibiotic resistance, most of the time we can just administer a different type of antibiotic and then thereby cure the patient. So very few patients really die as a result of antimicrobial resistance at the current time. Also, the urgency of the AMR problem may depend on the geographic context. So if you compare different continents, for example, you can see that antimicrobial resistance is much stronger and much more prevalent in the South Asian subcontinent, so in India, where a lot of overprescribing has happened for many years. So AMR may be more urgent in certain areas than others. Additionally, we have a really interesting structure to this problem called the principal-agent problem, or principal-agent relationship. Again, this is a theory or like a concept that comes from economics originally, but we believe it's very appropriate and very applicable here. And basically, principal-agent relationships refer to any relationships where one person, an agent, makes decisions or takes actions on behalf of another person who is called the principal. So just to kind of visualize this in a little diagram here, the principal could be anybody. So if you actually think of a daily situation, maybe someone's toilet breaks and they call in a plumber. In that case, whose toilet is broken, I would be the principal because I'm employing the plumber, who's the agent, to then perform an action, fix my toilet. In the context of antimicrobial prescribing, the principal would be the patient who comes into the hospital, requests treatment because they want to get better, and sort of employ the doctor as an agent who should then make the right prescribing choice to make sure that the patient recovers. So all agency relationships can be described as a contracting relationship in which an agent carries out an action on behalf of a principal who is reliant on the agent's expertise. So all relationships are characterized by an asymmetry of information. The principal lacks complete information about the capabilities of the agent. So obviously in our example of the doctor-patient relationship, the patient will usually have less information. They didn't go to med school. They don't really know much about medicine in most cases. So they very much have to rely on the doctor making the right choice. However, actually observing and measuring the agent's performance, so the doctor's performance, can be quite costly and very difficult to do. So for a patient who comes in very sick, they can't really assess whether the doctor is doing the right thing for them. And that makes it very difficult to then perhaps trust the agent in this case. So if we go back to our little diagram here, just to point out again, the decision maker, so the doctor in this case, is not the one directly affected by the treatment choice. So it's kind of like another person in the middle who's making that choice for the principal. And really, based on what I've said just before, we need to make this diagram a little bit more complicated and add additional aspects to it. So we have our patient here. They've obviously got a self-interest in getting better. So they're not interested in AMR or the overall society. They just want the antibiotics. And perhaps the doctor there has got some interest as well. Perhaps they're interested in their reputation. Perhaps they're worried how they might be perceived by their fellow colleagues. But perhaps they're worried by making the wrong decision that they might get reprimanded by their colleagues or superiors. And then there's always the question of competency here. I know doctors usually undergo a lot of training, many years of medical school, but that doesn't mean they're perfect in making decisions. I have to say this, my partner is a medic, he wouldn't like me talking about this, but he quite openly admits that antibiotic prescribing is not his area of expertise. It's quite a complicated field, and unless you're an infectious disease specialist or a microbiologist, you might not actually know that much about antibiotic use. So there is definitely a question there about the competency of the doctor. And then to make this just that much more complicated, actually, we have to think or question whether there's just this one principle. So initially we just focused on this part here of the diagram, saying that the patient here is the only principle. But really, if you consider it, the doctor not only has a responsibility to the patient, They are also obviously employed by the hospital or perhaps by the National Health Service, or depending on which country you're at. So they have another employer there, in addition to the patient, whom they have some responsibilities to. So in their prescribing choice, they not only have to consider the patient wishes, but also possible hospital regulations or possible guidelines that they might stick by from the hospital. And so it's really a very complicated relationship here that makes the prescribing choices just that much more complicated. So that's a theory bit for now. Just to quickly summarise before we go into the empirical data part, antibiotic prescribing can be conceptualised as a social dilemma. It shares features of the tragedy of the commons, so that was the example with the farmland, but it may be just that bit more complicated due to the lack of visibility and imminence, with it being a problem of the future almost, and due to it being a principal agent problem where we have that awkward position of the doctor as the main decision maker instead of the patient. So perhaps it is time that we slightly revised this diagram that I showed you in the beginning. Perhaps it's not really just the patient and society that needs to be considered here. Perhaps we need to put the doctor in the forefront as a decision maker, and we need to maybe slightly adapt the picture of society to show that element of uncertainty and lack of visibility. Now, we wanted to look at this and find some confirmation actually for it, test it basically with some empirical investigation of antibiotic prescribing. So, as I said before, we conducted a qualitative study across 3 different countries. So we developed a common interview topic guide, which was then administered in all 3 countries by local research associates in each of the different countries. We started with the UK, where we had 15 participants across 2 public hospitals in East Midlands. So that was in Leicester and in Birmingham. There's some pictures of the hospitals there, again looking very grey and rainy actually, not very surprising. Then we had South Africa, where we sampled 13 different participants. We had a private hospital and a public hospital. That one is actually the public one, and that's the private one. And we chose those 2 hospitals to reflect the different healthcare landscape in South Africa, with a very large private sector. So whereas in the UK the private sector is very negligible, in South Africa that's a completely different story, with quite a large part of healthcare sector being privatised. We focus very much on the Western Cape of South Africa, which is more developed than other parts of South Africa. So that's just something to keep in mind to show that perhaps the results are not fully representative of the entire country. And then we recruited 18 participants from Sri Lanka. We actually had 3 different hospital sites there. So this one in the top corner here, looking nice and fancy, that was the private urban hospital in Colombo. And we had a public hospital in Colombo. And down there, looking rather shabby, and it really was, that's a public and rural hospital, sort of in the hill country of Sri Lanka. So I'm going to talk you through some of the main results. So all of these are qualitative results, so I'll be talking about some themes from the data and also give you example quotes for all of these themes. And then after presenting the main results, which mostly pertain to the social dilemma aspects that I've presented before, I will also talk about some more context-specific findings that apply to the 3 different countries that we studied. So first of all, we found across the board actually a lot of confirmation of our social dilemma theory. And there were quite a lot of doctors who clearly perceived the social dilemma of antibiotic prescribing. So on the one hand, they noticed the patient demand. So someone here in the UK said, when you've got 20 other patients to see, you've got more patients coming in, yes, easy to give the prescription, give the antibiotics, which I know is not really going to cause too much harm to them, but it gets them off my back, they do it. So they can see with patients coming in, there is the demand for antibiotic prescribing. And on the other hand, they recognise the existence of other stakeholders, such as the hospital or wider society, with one example statement being, for the hospital, the downside is you are increasing the chance of resistance, and you create that resistance almost in your catchment area. So you then bring those patients back to your hospital, the problem comes back to you. So there's very much there's definitely that recognition of the two sides and the conflict between the individual and society. However, we also found support for the issues of lack of visibility and imminence. So very often, the problem of AMR was dismissed as a vague and very future threat. So an example quote again was, generally speaking, we're talking about what happens right here, right now, not 20, 30, 40 years down the line or even sooner. And the longer-term antimicrobial resistance is the last thought process. So clearly they know about AMR, but they just don't really care that much because right now, right there, it's not really that relevant to their patient treatment. And then similarly, when we ask them, do you worry about the problem of antimicrobial resistance in your day-to-day practice, we received answers like this one, not day-to-day, I have to say. For patients in front of me, I still have enough faith in antibiotics that they're going to work, driven on by the fact that, broadly speaking, they do still work. So again, it just shows that in the UK, the problem has not really progressed far enough for it to cause a main concern to the doctors. However, this did vary a little bit across context, and in Sri Lanka and in South Africa, where generally we do observe higher resistance patterns, there was on the whole more recognition for the threat of AMR. So one doctor in South Africa was saying, I've been on the side of getting patients with multi-drug resistant organisms that die under your hands, and you just think, God, they didn't anybody see this coming? I think my experience weighs a lot in making me think about what I do. So just to point out, this was not a common statement across the board and very much depended on the individual experience with multi-drug resistant organisms, but those people who did experience resistance certainly had a different attitude to the problem. Now, we also had quite a lot of interesting quotes concerning that agency relationship, which I outlined earlier. So on the whole, it seemed that doctors were very uncomfortable with their role as agents or decision makers, and that they weren't really clear about their contracts with hospital on the one hand, and then society and the patients as well. So one quote was, so I think a lot of antimicrobial prescribing issues come from the risk to society of me prescribing an antibiotic when I don't need to, is shared amongst the entire global population. Whereas the risk to me not prescribing antimicrobial comes squarely back on my team's shoulders. So you get really disproportionate risk, which I think is why people often err towards giving the antibiotics. So there's doctor saying here, I have to make this very difficult choice, but in the end of the day, only I get blamed if I get it wrong. So there's nobody really kind of patting him or rewarding him for a good antibiotic prescribing choice where they maybe hold back and wait for test results to come back. Instead, they receive very quick blame when they make an error, perhaps, and the patient dies as a result. And generally, it was very obvious that the agent, the doctor, felt more obliged to the patient as a principal than to society. And again, that fear of litigation complaints is very much at the forefront there. So one doctor said, because if someone dies and they go and it becomes a coroner's case and they're asking why wasn't antibiotics given, it's far easier to say I gave antibiotics and I gave antibiotics inappropriately than I didn't think there was an infection not to give them. So similar to the previous one, just they're trying to cover their backs by making very safe choices. And this one is a really long quote, but I like this one very much. I was actually the person interviewing the participant. He was a junior doctor on an acute medical ward, very interested in the topic actually, and engaged very much and gave me some fantastic quotes. So here we go. The hospital is split in a horrible dichotomy between those two stakeholder groups. So there's sort of sepsis squad in the hospital, so there's normally a sepsis champion nurse on every ward. They're always pro-antibiotic, and they will push you very hard if you're not prescribed the antimicrobial. And even if you perceive there's no indication for it. And on the other hand, you've got your public health team and the microbiologists that are very in line with society's wishes and seem to push us away from prescribing antibiotics. And then I get stuck in the middle of it, where in cases where there's uncertainty, I know that I might be prescribing an antibiotic that there's no benefit for and endangering society. And I might not be prescribing an antibiotic that there is an indication for that I haven't worked out yet, and it's endangering the patient. And my indemnity provider, I think, would rather I just gave the antibiotic because there's less chance of coming to harm. So he very clearly expressed that horrible situation of having multiple different people trying to pull you into different directions. And there is that mentioning of sepsis here, which actually will crop up in a later quote as well. So sepsis has been quite big over the news. Actually, we were just discussing it over dinner yesterday, and it's basically almost like the worst scenario outcome of a severe infection when your organs start shutting down. So when you notice those symptoms of sepsis, you initially administer antibiotics very quickly in order to prevent that outcome from happening, because patients will eventually die. But because of that worry about sepsis, antibiotics are often overprescribed. So it's almost like sepsis is the other side of the coin, with more judicious use of antibiotics being on the other side. Now, I also, like I mentioned, I also have some context-specific results, not specifically referring to the social dilemma theory. And I will present those in two broad categories. So firstly, I present some considerations that were made while initiating the antibiotic prescription. And then afterwards, I will talk about some of the thoughts and themes that came up when doctors were thinking about stopping an antibiotic treatment or switching it. So as I said before, kind of linking in with that sepsis quote earlier, in the UK there was a very heightened awareness of that sepsis risk. So it's been all over the news. There have been lots of local guidelines and policies developed. We have this lovely slogan saying "Start smart and then focus," which basically means if there's any suspicion, if you suspect sepsis, you should go start smart, but with very broad spectrum antibiotics straight away. And then if the threat kind of goes away, then you can maybe narrow it in and change your treatment. But often that second part basically doesn't happen, and there's very much the pressure to prescribe very quickly. So one example quote here was, "It feels like there's pressure, whether it be national or local, for avoidable sepsis deaths. We tend to give antibiotics more often now, even if there's a bit of a grey area, because it's deemed safer." So that was something that particularly came up in the UK, not so much in the other countries where those guidelines didn't exist so much. But it just shows that there are a lot of conflicting targets for doctors in the UK, and they have to make sense of all this different information they're presented with. In South Africa and Sri Lanka, on the other hand, a major problem was late patient presentations. So patients turning up to hospital in a very severely acute state where they're already very sick. So one doctor in South Africa said, "Well, when they present, they're quite sick, so you really have to start off with a broad spectrum. And they come from locum clinics where initially they had antibiotics, there was no cultures beforehand, so you're sort of shooting in the dark initially." So they're basically saying by the time that the patients get there, they have to act. They don't have times for tests. They just have to do something, otherwise the patient would die. And similar in Sri Lanka, here, being a district where the literacy level is very low and the education level is very low of the patients, and the infrastructure is also very low, so they present at the hospital quite at a late stage. So when they come in with an infection, if we delay the antibiotics, the prognosis is definitely going to be poor. So if you have that particular issue in your country where patients come in very late, then you just don't have the time to do all the tests and to hold back on prescribing. And that was something that was very much the case in South Africa and Sri Lanka. In Sri Lanka, additionally, there were big issues of overcrowding and healthcare-associated infections. So those are infections that spread across the hospital, basically, from one patient to another. And one doctor said, "Our system is so congested, so everybody will get some infections. So then we are compelled to start them on certain other broader spectrum ones, as well on top of the ones they're already being given. So that is also a problem. So we might need more space and resources, because it's not just the antibiotics and the bug, it's more broader than that." So basically in Sri Lanka, everybody is very, very aware of the lack of resources. So just to give you a feel for this, we visited a local rural hospital in Sri Lanka, and people were sharing, I don't know whether you can see it, but patients were sharing the beds, basically. There were at least 2 patients in each bed, and that means that obviously each infection was spread very easily. And almost in a preventative way, doctors will then administer antibiotics to every patient just to prevent those infections from spreading, which then obviously increases antimicrobial resistance in the whole environment. And then another factor in Sri Lanka was the poor quality of antibiotic drugs that were available. So a lot of the public hospitals in Sri Lanka were using drugs that were locally produced and had some questionable efficacy levels. So basically they didn't always work, and doctors were really worried about them not working. So sometimes they ended up prescribing more of them, or lots of different antibiotics, just to make sure that at least one of them would work. So here's the quote for that. Certain times of the antibiotic quality, we're very worried because it's a government hospital and we know that we're not getting the best one. So we have that in our mind and we have to provide a treatment quickly for the patient. So considering all these only broad spectrum antibiotics, and sometimes polypharmacy is practiced. Then another issue, and that was particularly actually in private hospitals, so both in Sri Lanka and South Africa in the private sector, that was patient demand. So you have to consider, so a private hospital basically works almost like a little business. So doctors want to keep their patients happy, they want to get good recommendations, they want to get new patients in the future, because otherwise they won't make any money. So some of the quotes here were, the private sector, that is what I have to face in daily situations. Because if a patient comes, say they've got a urine infection, before I start antibiotic based on culture and see if the patient's not needing it. So in those situations, those patients are not happy. So sometimes patients pressurize you to give antibiotics. And in South Africa, I think in private, really more than in public sector in South Africa, we have an issue of pressure because patients are very much in your face and they're very easy to say they will sue you or whatever. So in those environments where it's really very much depending on patients' recommendation and patient satisfaction, the patients really have that pressure and can basically demand antibiotics from their doctors, which then obviously often leads to overprescribing because some of those demands will be misguided or based on wrong beliefs or misinformation. Now, I just go quickly through some considerations that came up while stopping or switching antibiotics. So in the UK, we encountered quite a lot of risk-averse attitudes along the lines of never change a winning team. So one example quote was, people think, oh, meropenem's working, they're improving, might as well just finish off. So what we found was if a patient was on an antibiotic, on maybe a very broad spectrum antibiotic, and they were improving, then doctors didn't really want to switch it to perhaps a more targeted treatment approach or stop them just because they felt like, oh, it's going so well, why would I risk that? And then in the UK, we also had a massive issue actually of discontinuity of patient care, with patients moving across lots of wards actually once they were entering the hospital. So one doctor said, this idea, one dose and step down later. But everyone's thinking, I just give this one dose and someone else cleverer will come along and make that. But most patients will stay here for a day or two. And if they're staying in, they'll go to ward where some new person will take over their care. So yeah, I think we all, us juniors and the consultants, are guilty of that, just writing a plan, continue. So because of that discontinuity and patients moving across wards, basically, every doctor would start with antibiotics, maybe with the intention to stop them or to switch them when it's necessary, but because by that point the patient will have moved on, it will never actually come to that. However, on the whole in the UK, there was quite a reassuring theme of the awareness that it's quite necessary to collect cultures to inform that stopping and switching. So even if it not always happens, there was an awareness that this might be necessary. So when we asked, how important do you feel it is to collect microbiology specimens in making antibiotic prescribing decisions, most doctors said something along the lines, well, it's very important because you can tailor treatment. You can target organisms, it reduces resistance and the unnecessary use of antibiotics. Now, while most doctors actually across all countries notice the importance of microbiology labs, again in Sri Lanka with very limited resource setting, there were some issues around that because simply they didn't have enough microbiology services and lab facilities available. So one doctor said, well, the hospital-wise, we do have some microbiology services. But then, of course, all over the island, we have a lot, yes. So that, of course, has to be improved. But I hope that things will improve. And again, going back to that Royal Hospital that we visited, that is actually a photo of their microbiology lab. So they had lots of containers where they collected samples, but those containers weren't cleaned properly. So a lot of the samples very much, the outcomes were very much confounded and you couldn't really trust or rely on them. So obviously doctors there would not believe in the test results they received. And in South Africa, there was also an issue around limited resources, but those were more about stewardship resources, so the resources used to optimize prescribing. So one doctor said, in this hospital, switching or stopping broad-spectrum antibiotics is not as likely as it should be. We tend to try and, with our antibiotic stewardship ward rounds, focus on that and make sure that patients are switched appropriately down and escalated. Unfortunately, we don't get to all the wards, and I know of some wards where carbapenems are given ad infinitum, or antibiotics are just not checked, whether the indications still exist or whether it's still necessary. So there is that. People are trying to change it, but basically due to limited resources, it's just very difficult to change existing prescribing cultures. So I've come to the end of the empirical results, just to briefly summarise those. On the whole, it seemed that our qualitative findings supported the social dilemma theory that I presented in the beginning. Very much showcased the complexity of the problem. So we did pick up on those complex agency relationships. Doctors felt very much that awkward position that they were put in, making decisions for their patients. And we also came across that limited visibility of the problem, where a lot of doctors said, well, it's a future threat. It's very vague. It's not really affecting my day-to-day decision-making. We also found quite a lot of context-specific challenges to antibiotic stewardship. Like I said before, obviously the countries that we chose were really different. So across 3 different countries, they had different resource levels and different local guidelines. Now in the UK, a massive inhibitor of antibiotic stewardship were the interfering sepsis goals. So doctors felt like they were presented with lots of different targets and lots of different conflicting information. And it was just very hard to kind of find the right balance in prescribing and make sense of that. In Sri Lanka, I hope I showed that they obviously struggled with very limited hospital resources and microbiology labs. So that was obviously specifically the case in the public hospitals, which were less well equipped. And basically, if you don't have a microbiology lab, then it's very difficult to target your treatment of antibiotics. And we saw both across Sri Lanka and South Africa that there were issues around the private sector because basically patients ended up demanding antibiotics and putting a lot of pressure on doctors, which then led to overprescribing of antibiotics. Now, to draw some conclusions, I hope what I've shown you today is that antimicrobial resistance is an urgent and dangerous health threat, and it should not be underestimated. Antibiotic prescribing can be modelled as a social dilemma, but this dilemma may be more complex than existing models suggest. There also are context-specific challenges. So basically, if we want to target this big health threat, we need more theory-based and context-specific interventions. Now, we've reached a stage in our project where we're currently thinking about possible interventions. So we're kind of writing follow-up grant applications at the moment. And there is quite a bit of useful theory actually provided by Eleanor Ostrom in her really fantastic book, 1990, Governing the Commons. So Eleanor Ostrom came up with quite a lot of recommendations on how to handle social dilemma situations. But as we said before, AMR being a very specific problem, you might need to slightly change and adapt those general recommendations. So one thing I'd like to point out here is point number 2, we need to raise the problem's visibility and highlight imminence. So one way that could be done is actually by distributing or disseminating resistance patterns locally in hospitals, just to show doctors how much resistance has already progressed, really. And another possible way actually is to use social and reputational incentives or sanctions. So reputation can be a really powerful motivator, for example, by highlighting particular stewardship champions, so particular prescribers who have a very conservative approach to, or very judicial approach to prescribing, and kind of rewarding them in front of people. That could be a very powerful motivator for other doctors to imitate them. Now, these are still under consideration. We're actually currently in the process of writing a theory-based paper on this, but hopefully you'll be able to read that fairly soon. We have had one publication out of this project so far, It's a literature review on qualitative research and antibiotic prescribing in hospitals, published in the Journal of Hospital Infection. So if that's interesting to you, I would recommend you take a look. Okay.